Hello dear students, I'm glad to start a second lecture of the section Pulpitis. My name is Tamara Dobrovina-Paris and I'm a senior lecturer of Dentistry and Orthodontics department. So let's start. Today's topic is acute forms of pulpitis, clinic, pathomorphology, diagnostics, differential diagnostics. Pulpitis is an inflammation of the tooth pulp. The pulpitis clinic was described 6,000 years ago by the Egyptians. In the 16th and 18th centuries, Ambrose Pair and Günther described in detail the inflammation of the tooth pulp. However, a scientific approach to the study of this disease became possible only at the end of the 19th century. The reaction of the pulp to damaging factors. The pulp of the tooth containing connective tissue, vessel and nerves, and is able to respond to the effects of damaging factors by developing protective reaction. Pulp damage can be caused by various reasons, and now we describe these reasons. The reasons or factors can be divided into two groups, external and internal. As for external, it is microorganisms, streptococcus, non-hemolytic, hemolytic, greening, staphylococci, fusobacteria, spirochetes, anaerobes, fungi, bacteroids, melanogenicus, and clostridia, and etc. And next external factor, traumatic factors. Preparation or excavation of dentin. Accidental opening of the tooth cavity is possible. Traumatic situations, just as impact, fall injury, or spot injuries. On this histological preparation, you see the dental tubules, which are demineralized and expanded and filled with bacteria. Next external factor is temperature factor. Preparation of hard tooth tissues without cooling. Lack of seal during the application of amalgam fillings. And physical factors, they are ultrasound and radioactive energy. This histological preparation shows us infiltration of tooth pulp by neutrophils in response to external influence. And let's learn the internal factors. Occur in the organism itself as a result of diseases of internal organs and systems. Retrograde pulpitis. The cause of inflammation may be antigen-antibody complexes, infections and allergic cause, penetration of microbes and their toxins into the pulp earlier as a result of caries. Let's observe the definition of pain. Pain is a peculiar mental state of a person, determined by a set of physiological processes in the central nervous system caused by some kind of super-strong or destructive irritation. The pain sensitivity of the teeth is several times higher than the surrounding soft tissues one. The object of action in the treatment of teeth are poorly permeable to anesthetics tissue of enamel, dentin, cement, and bone. Pain analyzer receptors. The views exciting in the medicine on the reception of pain reflect theoretical views that appeared in the 19th century and until recently were practically beyond doubt. Two views on pain reception were considered decisive: the presence of specific pain receptors and the perception of pain by any receptors when an irritation stimulus reaches a certain value. It is generally believed that there are two systems of transmission of pain impulses. Phylogenetically, a younger system action through A-delta fibers immediately provides information about the nature and localization of damage, local, rapid, or epicric pain. This system is called primary and interoceptive since it reacts mainly to external stimuli. Another system, more ancient and universal, acts slowly through C fibers, myelin-free, and transmits dull diffuse, long-lasting pain. It is called interoreceptive because it signals mainly about pathological processes occurring in tissues and organs. Let's learn the mechanism of toothache. The mechanism of pain in the dentin is explained to a certain extent by the hydrodynamic theory of Bramstone, according to which the occurrence of pain is explained by the movement of dentin fluid and the formation of nerve endings in the area of subodontoblastic plexus. Pain analyzer in the maxillofacial region. In the maxillofacial region, the pain impulse from the peripheral part of the pain analyzer is transmitted through the following structures: the Gaussian node, the caudal nucleus of the trigeminal nerve, the posterol central nucleus of the thalamus, the posterol central gyrus of the cerebral cortex. Basically, 20.5% of the volume in the tooth pulp is occupied by nerve fibers. There are two types of nerve fibers in the pulp: myelin A-delta and non-myelin C fibers. Myelin-free C fibers predominate. They make up 72%, which are also sympathetic, and myelin A-delta only 28%. There is a subodontoblastic nerve plexus in the pulp. The most nerve endings are in the horns on the pulp, in the central part of the pulp, less in the bifurcation area and root canals. Nerve elements can penetrate only a few microns into the predentin. There are no nerve endings in enamel mineralized tissue. The occurrence of pain is associated with irritation of the peripheral layer of the pulp, where odontoblasts are located, with a change in intrapulpar pressure, the release of pain-producing substance, histamine and prostaglandins. Nerve eliminates penetrate into the dentin by only a few microns, which doesn't explain the soreness during preparation in the area of the enamel-dentin junction, as well as the occurrence of pain from sweets. The hypothesis proposed by Laborie in 1970 deserves attention. deserves our attention. According to this hypothesis, serotonin released from lysosomes when the integrity of their membranes is violated due to the excessive irritation has a direct allogeneic effect and nerve termination to other allogeneic substances. So, the formation of toothache with the participation of serotonin is carried out according to the following scheme: irritation of the tooth tissues, the occurrence of nerve impulse, the release of serotonin, next become spasm of brain vessels and cerebral hypoxia, and becoming a pain. Theory of odontoblastic transformation. Mechanical irritation of dentin due to preparation, for example, leads to the destruction of odontoblasts with the release of histamine-like substances and their effect on nerve endings in the subodontoblastic layer of the pulp. Damage to the processes of odontoblast cause electrical surface changes that spread to the nerve elements of the pulp. Confirmation of odontoblastic theories is the effectiveness of the use of drugs denaturating the processes of odontoblasts in hyperesthesia. And let's learn general characteristics of symptoms in pulpitis. They are spontaneous acute pain, increased pain in the evening and at night, paroxysmal character, and the duration of the pain attack. Spontaneous pain. The intensity of the pain attack and its frequency depend on the severity of the clinical cause of the inflammatory process. The occurrence of spontaneous pain is explained by the following: circulatory disorders, irritation of nerve endings, bacterial toxins, products decay of dentin and pulp. With pulpitis, the pain attack continues for some time after the stimulus is eliminated. A healthy pulp perceives heat at temperature of 50 till 60 and feels cold at 15 till 22. Increased pain at night. For acute pulpitis and exacerbation of chronic pulpitis. This is due to the predominance of the parasympathetic nerve system over the sympathetic at night. Increased pain is associated with a slowdown in the rate of cardiac activity and blood circulation at night, which leads to accumulation of toxic metabolic products in the pulp that cause irritation of nerve reception. The paroxysmal type of pain with pain-free intervals is characteristic of acute pulpitis and exacerbation of chronic one. This alternation is associated with the adaptive ability of the body to perception of prolonged pain, to fatigue of the nerve system, and to periodic compression of nerve receptors as a result of pulp edema. Often, pain radiates along the branches of the trigeminal nerve. Pain, irradiation. For lower jaw. With pulpitis of incisors, canines and premolars, the pain irradiate in the chin. The pulpitis of the first and second molars irradiate to the ear. With pulpitis of the eighth teeth along the anterior edge of the sternocleidomastoid muscle. And for the pain irradiation for the upper jaw. Pulpitis of incisors, irradiation to the suborbital region. Pulpitis of canines in the nose. Pulpitis of premolars in the eye. Pulpitis of sixth teeth temporal fossa. Pulpitis of the seventh and eighth teeth in the mandibular joint and the lower jaw proper. Remember, with pulpitis of the frontal teeth, pain may radiate to the opposite side of the jaw. And we'll start to learn them objectively. Upon examination, a deep carious cavity is determined. Probing is painful either at one point or all over the bottom. Percussion can be weak and painful. All kinds of stimuli cause amplification pain. The same effect is given by perforation of the arch of the tooth cavity, accompanied by discharge exudate. Radiography. Changes in the periodontal region mostly missing. The electrical excitability of the pulp is reduced throughout the bottom of the carious cavity from 15 microampere up to 16 till 80 microampere. We can differentiate all acute forms of pulpitis among themselves with concrementous pulpitis, with acute apical periodontitis and exacerbation of chronic periodontitis, trigeminal neuralgia, inflammation of the maxillary sinus, alveolites, and periodontitis. Let's learn the pathological anatomy. With inflammation of the tooth pulp, a complex of functional and structural changes characteristic of inflammation in general, alteration, exudation, proliferation develops. However, the inflammatory process in the pulp of the tooth differs in a number of features that should be taken into account when helping a patient with pulpitis. Sharp, exudative manifestations come to the fore since from the earliest stages of development, pulp inflammation proceeds in a hyperergic type, contributing to a sharp edema of pulp tissue. As a result, the pulp volume increases, the nerve elements experience significant irritation, the impact that manifests itself in the clinic pain syndrome. You see the histological preparation of pulp hyperemia. Damage to the nerve fibers innervating the vessel causes even greater disorders in the pulp, along with disorganization and their partial death. There are dystrophic changes and death of fibroblasts, histiocytes and other cells, destruction of collagen fibers. The severity of the inflammatory reaction and the nature of the reparative processes largely depend on the intensity and duration of exposure to the damaging factors. A certain role is played by the age and reactivity of the individual. With massive exposure to a damaging factor and the development of severe vascular disorders, dystrophic and destructive processes occurring rapidly in the pulp lead to its death and do not allow for the manifestation of its ability to regenerate. The inflammatory reaction gradually subsides under the influence of cytokines and growth factors secreted by various cells. You see the significant accumulation of inflammatory cells in the crown pulp. Small vessels and twigs of nerve fibers first grow around the damaged area and later grow into it. Their activity of fibroblasts is activated, as a result of which a large number of collagen fibers are formed in the area of damage. The outcome of acute inflammation of the pulp may be its necrosis or the process goes into chronic stage, giving rise to one of the forms of chronic pulpitis. This form is called exacerbation chronic pulpitis. On this histological preparation, you see the empty spaces in the subodontoblastic layer and micronecrosis with accumulation of the pus. Granulocytes dominate both inside and around blood vessels. Blood vessels and granulocytes dominate around it. You see the neutrophil granulocytes, they migrated from the pulp to the dentin tubules. And start to describe the clinic of different forms of pulpitis. Hyperemia of the pulp. It is the initial stage of pulp inflammation. Pulp hyperemia can be a transient condition under stress, climbing to a height, lowering to a great depth in water, hypertension. The patient have a complaint. Sudden attack of spontaneous pain during half till 1 minute, occurring at night. Sometimes lightning fast pain, sometimes pain on cold or hot under the action of chemical irritants, persisting up to 2 minutes after removal of the stimulus or irritants. Objectively, during examination, a carious cavity is determined within the near-pulp dentin with a narrow entrance made with light softened dentin. Bottom probing is painful, percussion is painless. A cold test causes an attack of pain that doesn't disappear after the removal of the stimulus for 1 till 2 minutes. Electroodontometry detected 15 till 18 microampere. Differential diagnosis performed with deep caries and with acute local pulpitis. And let's observe the common size with acute deep caries. It is pain under the action of temperature and sometimes chemical stimuli. The presence of a deep cavity within the near-pulp dentin. The soreness of the bottom during probing. Electroodontometry 15 till 18 microampere. Differences with acute deep caries. Pain disappears after the stimulus is eliminated, and absence of spontaneous night pain will detect it whether this diagnosis is acute deep caries, but not hyperemia of the pulp. Common signs with acute local pulpitis. The presence of spontaneous night pain, carious cavity within the near-pulp dentin, increased pain and the occurrence of an attack of pain under the action of temperature, for example, cold stimuli. And what about differences in acute local pulpitis? The period of pain will be 3 till 5 minutes, interpay period just about 2 till 4 hours. When probing the bottom of cavity, pain in 1 point. Electroodontometry up to 25 microampere. And now I'll tell you about pathomorphological changes in pulp hyperemia. The vessels of the pulp are dilated, full-blooded, vacuolization of odontoblasts. Near the bottom of the carious cavity, cirrhosis infiltrate. And the next form, acute local pulpitis. There is the second stage of pulp inflammation. The patient have a complaints for spontaneous pains that occur at night and under the action of cold stimuli lasting 3 till 5 minutes. From anamnesis, we know that the pain developed within 1 day on the day of going to the doctor. During the absence of pain, a cold stimulus causes a painful attack. Only part of the pulp is involved in the inflammatory process. The pain is localized. The patient can correctly indicate the diseased tooth. At night, the pain is intense. Objectively, during the examination, a deep carious cavity is determined. Dentin is light yellow to light gray in color in limited area. Pink pulp is visible through the thinned dentin. Probing the bottom of the cavity is painful at 1 point. The temperature test is painful. The percussion is painless. And additional methods of examination. X-ray examination indicated only to determine the localization of the carious cavity on one of the contact surfaces or the presence of periodontal pockets. Percussion is usually painless. Just for electroodontometry on the cusp in the projection of the affected area of the pulp, from 18 till 25 microampere. Differential diagnosis makes with pulp hyperemia acute diffuse pulpitis and chronic fibrous pulpitis with a closed tooth cavity. Common signs with acute diffuse pulpitis. The presence of spontaneous pain which increase at night, The occurrence of an attack of pain under the action of cold stimuli or irritants, the presence of a cavity within the near-pulp dentin. And what about differences in acute diffuse pulpitis? The pain attack lasts from 5 minutes to 2 hours. The pain radiates along the innervation of the trigeminal nerve. Probing is painful through the bottom of caries cavity, and the percussion of the tooth can be painful. Electroodontometry 25 till 35 microampere. Common signs with chronic fibrous pulpitis. Possible pain due to the action of external stimuli when probing soreness at one point. Differences in chronic fibrous pulpitis. More often, aching pain under the action of mechanical stimuli. Absence of characteristic attack of pain, spontaneous, mostly at night. The patient cannot point to the causal tooth. Deep caries cavity made with pigmented dentin. And electroodontometry will be 30 till 40 microampere. Just few words about pathomorphological changes in acute local pulpitis. There is edema in the pulp, limited infiltration closer to the bottom of the caries cavity. Odontoblasts are vacuolized, disorganized, blood vessels are dilated and full. And another form of acute pulpitis is acute diffuse pulpitis. The patient have a complaint on spontaneous paroxysmal pain increasing at night and under the action of cold stimuli. The duration of pain is from 5 minutes to 2 hours. From the anamnesis, we find out that the first attack of pain was 1-2 days before going to the doctor. The nature of pain is developed. The pain radiates along the branches of the trigeminal nerve. Objectively, the deepest caries cavity with a huge amount of softened dentin, pink pulp is visible on the bottom. Probing just one is painless. Vertical percussion can be painful. A cold test causes an attack of pain. The patient cannot point to the causal tooth. Changes from the periodontal side are most often absent. Electroodontometry 30 till 45 microampere with the involvement of the entire pulp. Differential diagnosis you can make with such diagnosis. Acute local pulpitis, acute purulent pulpitis, acute and aggravated apical periodontitis, trigeminal neuralgia, and exacerbation of chronic pulpitis. Let's learn the common size and differences with acute local pulpitis were named earlier. Common signs with acute purulent pulpitis. The presence of spontaneous pain increasing at night, irradiation of pain during the innervation of the branches of the trigeminal nerve, positive percussion. And what is the differences? With acute purulent pulpitis, the pain is throbbing, tearing, shooting, almost constant. The pain increases from the hot and calms down with the action of the cold. Electroodontometry 40 till 50 microampere. Common size with acute and aggravated apical periodontitis. It will be only one common sign is positive percussion. And the differences. The pain is aching, constant, lack of reaction to temperature stimuli, bottom probing is painless, electrodontometry above 100 microampere. There may be tooth mobility and swelling of soft tissues around the tooth, expansion of the periodontal jab during X-ray examination. Common signs with trigeminal neuralgia. It is spontaneous, paroxysmal pain, irradiation of pain in the course of innervation of the branches of the trigeminal nerve. And the differences with trigeminal neuralgia. The presence of trigger zones. Appearing pain more often in daytime. The analgesic effect is provided by dry heat. The pain attack is relieved by analgesics. And let's know about the common signs with aggravated chronic pulpitis. It is acute, spontaneous paroxysmal pain, intensifying at night. The pain radiates along the innervation of the branches of the trigeminal nerve. The patient cannot indicate the causal tooth. Probing is painful. Tomal test causes an attack of pain. Percussion is painful. And the differences with aggravated chronic pulpitis. In the anamnesis, we know that there were previous bouts of pain. The carious cavity communicates with the tooth cavity. Probing is painful at the point of communication with the tooth cavity. And you see the pathomorphological signs of acute diffuse pulpitis. Edema of the crown and root pulp infiltrates from round cells, odontoblasts are discomplicated, vacuolicite, the disappearance of hyaluronic acid, the vessels are full-blooded, thickened, and hemorrhage. And the next acute form of pulpitis is acute purulent pulpitis. The patient complains. For this form of pulpitis, spontaneous pain of an almost continuous nature in the corresponding jaw are typical. The pain is throbbing, tearing. The attacks of pain do not completely disappear, but only weaken for a short period of time. Heating changes painful sensation, and the cold calms, a symptom of cold bottle. Body temperature sometimes it rises to 38. The patient indicates that the pain occurred a few days ago. Gradually the pain increased. The patient cannot point to the causal tooth. Objectively, during examination, a deep carious cavity is determined within the near pulp dentin. The dentin on the walls and at the bottom of the cavity is light. Probing all over the bottom is painful. The dentin is softened, easily removed. The heat test is painful, causes an attack of pain. The cold test is painless. Vertical percussion is sharply painful. Electrodontometry 30 till 60 microampere. The reaction to percussion is expressed in 15 to 20% of cases. The fusiness is determined on the X-ray bone structures in the area of the tops of the roots. We can make a differential diagnosis with such diagnosis: trigeminal neuralgia, acute apical periodontitis, acute diffuse pulpitis, and acute maxillary sinusitis. Common signs and differences with acute diffuse pulpitis were named earlier. With acute apical periodontitis and trigeminal neuralgia are the same as with acute diffuse pulpitis. And now we learn the common size with acute maxillary sinusitis. It will be throbbing pain, almost constant, intensive at night, and positive percussion. Differences with acute maxillary sinusitis. Stuffy half of the nose, headache, body temperature rise to 39, easing of pain when changing the position of the body. Cold doesn't eliminate the pain. Dimming of the maxillary siemens during X-ray examination. Pathomorphological examination of the pulp in acute purulent pulpitis. Purulent exudate prevails. A lot of areas of necrosis, a lot of white blood vessels, microabscesses. The cells are in a state of destruction. Vascular disorders. Nerve fibers are vacuolized and fragmented. And just a little information about acute traumatic pulpitis. If it is accidentally opened pulp or complication in the preparation process. The patient have a complaints of sharp pain during the preparation of the bottom of the caries cavity, during probing or during the excavating of the dentin. Upon examination, the open tooth cavity and a drop of blood are determined. The cold test is sharply painful. Percussion is painless. Electrodontometry 2 till 6 microampere. The result of household sports and transport injuries can be if it is the fracture of the tooth crown. And acute traumatic pulpitis caused due to this factor. Complaints of sharp pain when talking, tongue movement, on examination, a fracture and bleeding pulp. Sharp soreness are determined. Dear students, for today that's all. I wish you a nice day and traditionally see you at our classes.